When 1933 began, German medicine operated with the stability of a system that had accumulated decades of academic and clinical work. Its university hospitals, research institutes, and public health networks maintained standardized procedures and a centralized administrative structure. That solidity allowed that, once the new government was installed, the state guidelines were quickly integrated. The political reorganization of the country soon reached the health sphere, and in a few months, medicine became a key instrument for applying racial criteria from the public administration. The law for the restoration of the professional civil service, enacted in April of 1933, initiated the systematic purging of medical personnel. Although the text spoke of reorganization, its application implied the immediate expulsion of Jewish doctors and professionals politically identified as opponents. In hospitals and faculties, contracts were rescinded without a review process, licenses revoked, and teaching positions replaced with new appointments linked to the party. The medical associations, traditionally managed with relative autonomy, came to be directed by Nazi officials who aligned their activities and publications with the principles of the racial state. Specialized journals began to disseminate articles where biological heritage appeared as a basis for defining social belonging and establishing health priorities. The universities adapted with remarkable speed. Mandatory courses on racial hygiene, hereditary biology, and eugenics were incorporated. Professors who previously worked in traditional clinical areas began to participate in courses where they taught how to identify characteristics considered hereditary, develop genealogies, and record anthropometric parameters. The Kaiser Wilhelm Institute of Anthropology, Human Heredity, and Eugenics was established as a reference for this orientation. Under the direction of Eugen Fischer, its researchers developed cranial measurements, facial analyses, and pigmentation classifications that were presented as scientific tools to evaluate the biological composition of the population. These practices, directly linked to the official discourse, provided an apparently technical framework to justify exclusion policies. In that context, the regime took a decisive step with the law for the prevention of offspring with hereditary diseases, promulgated on the 14th of July 1934. The regulation established the mandatory sterilization of people diagnosed with disorders considered hereditary, including schizophrenia, epilepsy, congenital deafness or blindness, severe malformations, and chronic alcoholism. The implementation of this measure was entrusted to the hereditary health courts, bodies created in each judicial district. Each court was composed of a judge and 2 doctors who evaluated files, conducted rapid exams, and issued binding decisions. The procedure relied on standardized forms where diagnoses were reduced to checked boxes and brief descriptions, allowing hundreds of cases to be processed with an administrative efficiency that the regime considered exemplary. The number of sterilizations grew rapidly. By the end of 1934, more than 30,000 procedures had been performed. In 1935, the figure exceeded 70,000. By 1939, the cumulative total hovered between 350,000 and 400,000 interventions. Although the operations were presented as routine surgeries, post-operative complications were frequent, especially in women. Infections, hemorrhages, and serious sequelae that in many cases proved fatal. However, the internal reports of the Ministry of the Interior analyzed the data from a statistical perspective, comparing regions, projecting trends, and evaluating the budgetary impact of reducing the number of institutionalized people for diseases considered hereditary. The concept of the Volkskörper, the body of the people, provided the ideological basis that linked medicine and state administration. It was proposed that the nation functioned as an organism whose health had to be preserved through preventive measures. In this framework, hereditary diseases were not understood as particular situations, but as factors that compromised the biological integrity of the community. Professors like Fritz Lenz and Ottmar von Verschuer published studies that associated inheritance, intelligence, and behavior, which reinforced the idea that the state had to intervene to correct or eliminate factors considered harmful. The academic production, far from being limited to theoretical analysis, was integrated into the planning of public policies. In the mid-1930s, scientific conferences showed this convergence between research and administration. In 1935, international meetings held in Berlin addressed sterilization techniques, genetic diagnosis methods, and strategies for identifying carriers of hereditary diseases. Medical publications dedicated entire issues to racial hygiene, with calculations on the time needed to reduce the presence of certain traits considered undesirable. The language used in these studies reflected the growing acceptance of state intervention as a legitimate mechanism of biological ordering. Within the administrative apparatus, debates arose about the usefulness of maintaining psychiatric institutions with patients diagnosed as incurable. Some doctors linked to the regime argued that sterilization did not resolve the costs associated with the permanent care of these people. Although these discussions were not published in scientific journals, they appeared in internal memorandums and restricted meetings. In 1935, a confidential committee was formed to study the possibility of applying broader measures in cases of severe malformations detected from childhood. Its work consisted of compiling files, reviewing clinical criteria, and evaluating methods that would allow the reduction of certain patients' permanence in the institutional system. By 1938, the transformation of German medicine was complete. Doctors acted as biological administrators within a system where the priority was no longer individual well-being, but rather the preservation of the Volkskörper. Courts operated regularly, clinics applied standardized procedures, and universities trained professionals fully integrated into this framework. The resulting structure allowed the state to intervene in the lives of thousands of people through decisions presented as acts of public health. And at various levels of health administration, options began to be considered that surpassed sterilization as a control tool, particularly concerning institutionalized patients whose condition was evaluated as irreversible. These deliberations, not yet formalized, set the stage in which, starting the following year, medical intervention would assume broader functions within the state system. In the first months of 1939, various bodies of the German state had already incorporated racial and eugenic criteria into their daily operations. The network of hereditary courts was operating steadily, and the health system produced periodic reports on the situation of patients deemed incurable. Within that administrative framework, the Führer's chancellery took the initiative to expand the powers granted to certain doctors. At the end of September of that year, an authorization signed by Adolf Hitler without public legal value or official publication designated Karl Brandt and Philipp Bühler as responsible for implementing medical decisions for people for whom there was deemed to be no possibility of recovery. The document spoke of granting a merciful death, but the ambiguity of the language was deliberate. Its practical interpretation was left in the hands of the teams charged with executing it. The operation was named Action T4 after the address of its headquarters in Berlin, located at Tiergartenstrasse 4. From that building, a small group of administrators, doctors and technicians coordinated data collection, patient selection, and the transfer of these to specific facilities. The process was designed with strictly bureaucratic criteria. Standardized forms were developed and sent to psychiatric hospitals, sanatoriums, and centers for the disabled. The institutions had to record diagnoses, duration of stay, work capacity, and other clinical data. The forms were returned to Berlin, where teams of doctors reviewed them, having never seen the patients. The selection criteria were reduced to brief notes and color markers that classified each case according to its destination. The selection was made quickly. Conditions such as chronic schizophrenia, persistent epilepsy, or advanced paralysis were considered sufficient to authorize a transfer. Detailed medical histories were rarely analyzed. A prior diagnosis or mention of prolonged work incapacity was enough. Once the corresponding category was assigned, the central office issued transfer orders. Families received communications informing them that the patient would be transferred to a specialized center to receive appropriate treatment. Institutions sent groups of patients by buses or trains on routes designed to avoid public attention. The process was repeated continuously and without administrative interruptions. The transfers were destined for 6 facilities adapted with sections reserved for the operation: Grafenegg, Brandenburg, Bernburg, Hadamar, Hartheim, and Sonnenstein. From the outside, these centers retained the appearance of conventional medical institutions. However, in restricted areas, gas chambers had been constructed with specific technical advice. They were sealed rooms, equipped with carbon monoxide systems from industrial cylinders. The chambers were configured to receive groups of people and allow the observation of the process from an adjoining room. The staff followed regulated protocols, which included exposure times, subsequent ventilation, and the immediate transfer of the bodies to the crematorium. Once the procedure in the chamber was completed, the bodies were transferred to crematory ovens installed in the same facilities. Before cremation, doctors associated with the program carried out the extraction of organs of interest for neurological research institutes. Diagnoses and clinical characteristics were recorded, and the samples were sent to centers in Munich, Berlin, and Heidelberg. These shipments were documented through lists with the information associated with each case. After the cremation, families were notified of the death through certificates attributing the death to natural causes. When remains were requested, prepared urns without individual correspondence were sent. The internal functioning of the program depended on medical, administrative, and technical personnel who operated within stable work structures. Their tasks included sorting forms, supervising transfers, operating cameras, and managing crematories. They were required to maintain absolute confidentiality through formal declarations. Many employees incorporated the process into administrative routines that, outwardly, did not differ from tasks they had performed for years. Information circulated in closed circuits, and documentation was managed with efficiency criteria, typical of any large-scale state program. Between January of 1940 and August of 1941, the 6 centralized facilities executed the murder of more than 70,000 people. The pace of operation varied according to the capacity of each center. In facilities like Hadamar, the frequency of transfers and the volume of cremations increased the visibility of the process. The constant presence of smoke, vehicle movements, and the repetition of similar deaths generated comments among neighbors and external staff. Although official information was kept strictly secret, some sectors of the population began to question the causes of that sudden increase in deaths. The most organized criticisms came from religious sectors. In August of 1941, a sermon by Bishop Clemens August von Galen, distributed in printed copies, publicly denounced the practice of murdering patients. Although it did not mention specific places, the description matched the procedures applied in the program's facilities. The dissemination of the sermon caused concern among the authorities, who assessed the impact it could have on public morale. Consequently, on the 24th of August of 1941, the formal suspension of centralized operations was ordered. However, the suspension affected only the gas chambers. The elimination of patients continued in hospitals through pharmaceutical overdoses, deprivation of food, or deliberate neglect. This decentralized, unofficially recorded process prolonged over the following years and produced tens of thousands of additional deaths. The administrative structure of T4 was dismantled, but its staff did not remain inactive. Many of those who had participated in the selection, in the technical operation of the chambers, or in the administrative supervision, received new assignments. Their accumulated experience in logistics, transport, body disposal, and facility management was considered useful in other projects that the regime was developing in occupied territories, where the concentration camps already operated under consolidated structures and began to incorporate functions that would go beyond simple confinement. When the war began in September of 1939, The concentration camps existing in German territory had already been operating for years under a punitive logic that combined forced labor, extreme discipline, and isolation. Dachau, Sachsenhausen, and Buchenwald formed a network of institutions where the SS administration controlled thousands of detainees classified as political or social enemies of the regime. The original infrastructure had not been designed for medical functions, but the increasing presence of SS medical personnel altered their internal organization. Between 1939 and 1942, these centers began to develop a systematic practice of observations and trials that gradually transformed their function, turning them into spaces where biological data was collected under controlled conditions. The incorporation of permanently assigned doctors marked the beginning of this transition. Their official responsibilities included supervising hygiene, evaluating work fitness, and reducing the spread of infectious diseases. However, their activities soon expanded towards obtaining physiological information. The infirmaries, previously limited to attending to common injuries, were reorganized to allow for more detailed records. Examination tables, small laboratories, and storage areas for samples were added. The installation of these resources generated more comprehensive reports that began to circulate among SS medical units and the central offices of the camp system. In Sachsenhausen, the observation of physical deterioration caused by forced labor became one of the first lines of study. The prisoners performed construction tasks, material transportation, and excavation over long workdays with limited food rations. The doctors recorded weight values, recovery time after exertion, and visible changes in musculature and skin. The analysis was conducted comparatively between groups of prisoners assigned to similar activities. The resulting tables included dates, workloads, outside temperatures, and feeding data, allowing the development of patterns on the relationship between physical exertion and the ability to survive. Photographs played a complementary role. Some doctors documented the progression of bodily wear through photographic series taken at regular intervals. The images were filed alongside numerical records and allowed correlations to be established between the level of malnutrition and performance in assigned tasks. The goal was not therapeutic. Information was sought to understand the physiological effects of prolonged work under controlled conditions, a field of interest for various military and administrative branches. In Buchenwald, attention was directed towards the effects of continued physical violence. Corporal punishments, frequent in the administration of the camp, generated injuries that could be observed regularly. Doctors described the depth of wounds, the appearance of bruises, the duration of swelling, and the time required for healing. This data was compared among prisoners with different levels of nutrition and different work trajectories. The evaluation included simple measurements, such as the range of motion of injured limbs or the load resistance after receiving repeated blows. The resulting reports showed a constant accumulation of physiological data obtained through routine camp practices. In Dachau, the initial experimentation was focused on nutrition and infectious diseases. Doctors tested reduced dietary regimens to evaluate for how long a prisoner could maintain a certain work capacity with minimal rations. These trials consisted of modifying the composition of meals, altering proportions of bread, soups, and vegetables, and measuring their impact on daily performance and signs of weakening. At the same time, recurring outbreaks of infectious diseases led to the use of experimental vaccines sent from medical institutions and pharmaceutical companies. The selected prisoners received the injections without any information about their purpose. The doctors observed the appearance of symptoms, duration of the fever, and survival, comparing results with unvaccinated groups. These initial practices lacked advanced equipment. However, they established a functional framework in which prisoners were treated as subjects of study. The absence of consent, ethical supervision, or external regulations allowed the camps to operate as unrestricted experimental environments. This model attracted the attention of universities and pharmaceutical companies, whose representatives began to visit the camps to assess possibilities for collaboration. Some chemical companies sent preliminary stage products to be tested in conditions that allowed for the immediate observation of adverse effects. The return of results, in the form of brief reports, created an informal exchange circuit between the camp system and sectors of the German medical industry. The army also showed increasing interest. The need for data on physical endurance became more urgent as the war progressed. In Sachsenhausen, tests related to the ability to endure prolonged marches, lack of sleep, or exposure to low temperatures were conducted. Groups of prisoners were forced to carry out continuous movements within the camp perimeter, while doctors measured the time required for total exhaustion. Other tests consisted of rest deprivation, while performing repetitive tasks designed to assess loss of coordination and decrease in cognitive ability. The data obtained were recorded in comparative tables that analyzed times, physical limits, and correlations with nutrition and workload. By 1942, the three camps had developed a significant volume of documentation that included bodily measurements, clinical observations, mortality rates, and comparisons between groups. Some doctors presented internal reports at meetings organized by the SS, where methodologies were discussed, and adjustments were proposed to obtain more consistent results. These meetings allowed for the unification of criteria and served as a starting point for subsequent projects that required more specialized infrastructure. The observations made in this initial phase showed that the camps could function as spaces for systematic experimentation, and that the staff had the capacity to record useful data for different state institutions. The accumulation of this experience coincided with a growing interest from organizations linked to the war effort in developing procedures that required more complex facilities. While in Sachsenhausen, Dachau and Buchenwald, these low-sophistication trials continued, other camps began to reorganize to incorporate additional functions. One of them, located in occupied Poland, was expanding rapidly and combined forced labor with a structure that allowed large-scale processes to be implemented. In that environment, medical participation would take on a more decisive role within a system that was in full transformation. The formal suspension of the T4 program in August of 1941 did not mean the end of the system that had made it possible. The procedures developed in the euthanasia facilities, rapid classification, operation of gas chambers, ventilation, cremation, and minimal record keeping, were already part of the daily work of a group of doctors and technicians. After the closure, much of this personnel was reassigned to occupied Poland. Among them were figures like Christian Wirth, Franz Stangl, and Irmfried Eberl, all with direct experience in organized elimination processes. Their transfer responded to specific needs of the regime, which at that time was expanding a network of facilities whose aim was no longer re-education or forced labor, but the immediate elimination of population groups defined by racial criteria. Centers such as Chełmno, Belzec, Sobibor, and Treblinka began to operate in the occupied Polish territory. They were small facilities, without large-scale work infrastructure, designed to process human transports quickly. The gas chambers were constructed following principles learned in T4, although modified to handle larger quantities of people. Carbon monoxide continued to be used in several of these places, while technical adjustments were evaluated to increase efficiency. Operations were conducted with a logistical approach, where the arrival of the transports, the passage through the facilities, and the disposal of the bodies were integrated into a repeatable procedure. Unlike these centers, whose sole purpose was immediate extermination, Auschwitz had begun as a conventional concentration camp in 1940 and primarily housed Polish political prisoners. Its location near the city of Oświęcim offered considerable logistical advantages. An extensive railway network allowed access from different parts of Europe, and the area had room for expansions. In 1941, the authorities decided to transform the facility into a complex with differentiated functions. A system of three main components was established: Auschwitz I, the administrative headquarters of the complex; Auschwitz II Birkenau, progressively oriented towards extermination; and Auschwitz III Monowitz, built to provide labor to associated industries, particularly to the IG Farben plant. The expansion coincided with the arrival of SS medical personnel experienced in classification and elimination, many of them from previous programs. At Auschwitz, the medical service did not perform conventional health functions. Its main role was to determine the fitness of each transport. When the trains arrived at Birkenau, the prisoners disembarked on the ramp under SS supervision. The medical selection was carried out right there through a quick visual assessment. No medical records were compiled, nor detailed examinations conducted. The doctors decided who could be incorporated into the forced labor system, and who would be sent directly to the gas chambers. These decisions were made in a matter of seconds. The people selected for the work were registered, disinfected, shaved, and tattooed with a number. They were assigned a barrack, and from that moment on, their survival depended on their physical resilience and subsequent inspections that could lead to new internal selections. Those considered unfit were immediately sent to specially prepared facilities. In the first phase of the system, these facilities consisted of adapted buildings known as Bunker 1 and Bunker 2, where the walls had been reinforced and the openings sealed. Later on, the process was moved to crematoria, specifically constructed to combine underground gas chambers with cremation ovens on upper levels. Zyklon B, a pesticide that released hydrogen cyanide upon contact with air, began to be used as a lethal agent after initial trials conducted in 1941 in Auschwitz-Thurm. These trials showed that its application allowed for a faster process with less need for continuous technical supervision. In Birkenau, the permanent gas chambers were designed to receive large groups. The interior, presented as a shower room, was equipped with structural elements that facilitated the dispersion of the gas. Doctors supervised the process from the outside and certified death once ventilation was completed and the chamber was opened. In addition to these functions, the medical service intervened in the internal management of the camp. Prisoners who lost work capacity due to illness, injuries, or exhaustion were periodically reviewed. These inspections were carried out in the barracks or in designated areas where the doctors ordered the prisoners to present themselves naked to assess their physical condition. When it was determined that a prisoner could no longer perform useful tasks, the order for transfer to the gas chambers was issued. This procedure avoided the accumulation of people unable to work and maintained the functioning of the system. The existence of a constant flow of prisoners also allowed some medical units to start independent research projects. Although these projects would develop with greater complexity in later phases, specific procedures were already being carried out in 1941 and 1942, with prisoners selected on the ramps or in internal inspections. Some doctors used these prisoners in studies on physical endurance or infectious diseases, while others began to establish contacts with academic institutions interested in human material for research. These initial steps consolidated a link between extermination structures and the scientific needs of the regime. By the end of 1942, Auschwitz-Birkenau had fully adopted its dual function: immediate extermination and labor exploitation. The gas chambers operated according to schedules aligned with the pace of the transports, the crematoria functioned continuously, and the medical staff played a central role in selecting and managing the labor force. At the same time, spaces were being opened within the complex that would allow for more specialized research to be carried out. These areas, located in separate blocks, were being prepared for experimental projects that required specific facilities and personnel with advanced medical training. The system had reached a level of organization that allowed for the integration of multiple functions within the same operational set, and the doctors operating in this environment began to request additional equipment and resources to expand the type of procedures they could perform. In early 1942, the camp system had already acquired a structure that allowed for specialized medical operations. Dachau, active since 1933, had conditions that made it a suitable place for physiological experiments oriented towards the specific needs of the Luftwaffe and the Kriegsmarine. The military authorities were seeking data that would allow for the improvement of pilot survival subjected to pressure failures at high altitudes, or of crew members exposed to the icy waters of the Atlantic. These issues could not be resolved with animal studies or theoretical simulations. They required direct observations on human beings. In this context, the camp was designated as the site for a series of trials that analyzed the limits of the body's endurance under extreme conditions. The first block of experiments focused on the effects of extreme altitude. For this purpose, a military-designed low-pressure chamber was installed in Dachau. The device consisted of a hermetically sealed steel container equipped with measuring instruments, pressure controls, oxygen indicators, and observation windows. It allowed for the simulation of continuous ascents to levels equivalent to over 20,000 meters altitude, as well as sharp descents that mimicked the sudden depressurization of a cabin. The chamber was part of a laboratory operated by SS medical personnel, and the records were prepared with standardized observation protocols. The prisoners assigned to these tests were usually Soviet prisoners of war and Eastern European civilians, whom the camp classified as suitable only for experimentation. Once inside the chamber, the staff conducted progressive ascents and noted the moment when visible signs of disorientation, loss of motor coordination, or loss of consciousness appeared. In the case of rapid descents, doctors recorded the physical effects resulting from the abrupt change in pressure, which included severe respiratory alterations and internal damage subsequently verified through autopsy. Each session generated a detailed report describing the simulated altitude, the total time of exposure, the record of observed signs, and the findings obtained after the subject's death or irreversible deterioration. Such reports were sent to aeronautical research departments that evaluated these data to adjust flight procedures and technical recommendations for pilots. In parallel, a second set of experiments dedicated to the study of hypothermia was developed. The Kriegsmarine sought to determine the survival capacity of crew members fallen into cold waters, and especially to identify the most effective method for subsequent resuscitation. For this purpose, immersion tanks with water at temperatures close to the freezing point were set up in Dachau, and areas of the camp were allocated for controlled outdoor exposure during the coldest months. The body temperature of the prisoners was measured with standard clinical instrumentation, noting the progressive decline and the time required to reach severe hypothermia states. The trials included a resuscitation phase that compared different techniques. Methods based on external warming using heat lamps, warming by immersion in warm water, and direct body reheating procedures were applied. The results varied considerably, and many subjects did not recover vital functions despite resuscitation attempts. The reports described not only the effectiveness of each technique, but also the physiological complications that appeared after exposure to extreme cold, such as cardiac disorders, metabolic alterations, and tissue injuries verified by post-mortem examination. This documentation fueled debates in the Luftwaffe about air rescue procedures and survival strategies in polar environments. During 1944, Dachau incorporated a third axis of experimentation, this time focused on dehydration caused by seawater intake. The military goal was to assess whether emergency methods could be used to make salt water drinkable through simple chemical treatments. For this purpose, a group of prisoners was selected and subjected to different water regimens: exclusive ingestion of untreated seawater, consumption of chemically modified solutions with lower salt concentration, and periods of total water deprivation. The progression of each subject was documented with daily weight measurements, urine analysis, heart rate records, and observations of cognitive state. As the days passed, the reports recorded characteristic signs of kidney failure and severe dehydration, altered urine output, extreme weight loss, confusion, episodes of motor incoordination, and finally, coma. Subsequent autopsies allowed for the description of renal lesions and alterations in various organs related to osmotic imbalance. The results were presented at medical meetings and used to conclude that none of the experimental desalination procedures employed were adequate to ensure survival in real maritime emergency conditions. By the end of 1943 and during 1944, the set of reports generated in Dachau formed an extensive technical corpus. The altitude studies provided graphs and tables where barometric pressure levels were correlated with neurological deterioration. The cold experiments detailed thermal drops and resuscitation results according to the method applied. The seawater trials provided physiological values associated with different degrees of dehydration. The military utility of these documents was evaluated without reference to their origin, and the personnel involved focused exclusively on the results. The camp, for its part, had consolidated an experimental area with its own protocols, regular instruments, and a fluid relationship with scientific and military sectors interested in these data. These physiological experiments positioned Dachau as a specialized center within the camp system. However, in other places of the Reich, different lines of research were being developed that did not seek to measure human endurance in extreme conditions, but to intervene directly on the body through surgical procedures. In a camp intended exclusively for women, experimentation would take a more invasive form, marked by repeated interventions and procedures that required operating rooms, anesthesia, and staff trained in surgery. Ravensbrück, located about 90 kilometers north of Berlin, operated from 1939 as the main concentration camp intended exclusively for women. Its infrastructure included extensive barracks, forced labor areas, and a medical block equipped for surgical procedures. Starting in 1942, this facility acquired an additional function: to serve as a study site for experimental surgeries related to clinical problems that concerned the German army on the Eastern Front. Wounds contaminated with bacteria producing serious infections represented a constant challenge for military medical services, and the camp offered an environment where controlled clinical data could be obtained through repeated operations on selected subjects. The experiments were organized by Karl Gebhardt, an SS surgeon with wide influence in the medical circles of the regime. After the death of Reinhard Heydrich from a post-traumatic infection in 1942, Gebhardt argued that the available medications, mainly sulfonamides, could not have altered the outcome. To support this claim, he proposed systematic studies in Ravensbrück that would allow for the comparison of infected wounds treated with sulfonamides against wounds without pharmacological treatment. The stated purpose was to evaluate the validity of these medications in deep infections, especially those related to tissue contamination and muscle or bone involvement. The prisoners selected for these experiments were mainly young women classified as suitable for repeated surgery. The procedure started with anesthesia and an incision in the leg, opening skin, subcutaneous tissue, and muscles. Once the area was exposed, the surgeons introduced contaminated materials such as wood fragments, soil from muddy areas, or bacterial cultures prepared in the laboratory. The wound was then closed to reproduce the conditions of an infected traumatic injury. From that moment, a structured clinical follow-up was initiated. The patients were observed to record the onset of inflammation, the progression of redness, the appearance of fever, and other signs of systemic infection. In some cases, doses of sulfonamides were administered at different times. In others, no treatment was given to establish comparisons. In situations where the infection reached advanced levels, phenomena such as gas in the tissues or progressive necrosis could appear. Doctors documented these processes through photographs and detailed descriptions. Periodically, blood or tissue samples were taken for microbiological studies. In several cases, the patients died from septicemia. When this happened, the body was transferred to the morgue for an autopsy that allowed establishing the state of the internal organs, the extent of the infection, and the characteristics of the tissue damage. Once this first series of experiments had begun, Ravensbrück expanded its surgical activity with studies on transplants and tissue regeneration. In these procedures, surgeons extracted bone fragments from the legs, for example, segments of the tibia, to assess whether the bone could regenerate under conditions of malnutrition and prolonged physiological stress. In other cases, the extracted fragments were implanted in another patient to study the graft's integration capacity. Post-operative evolution, inflammatory response, bone consolidation, and residual mobility were recorded. Another line of work analyzed the resistance of muscle tissue. Some experiments consisted of the partial or total removal of muscle groups in the leg in order to observe if the organism could compensate for the loss or if permanent alterations occurred in walking. The observations included healing times, degree of atrophy, occurrence of secondary infections, and variations in joint mobility. The patients who survived were left with visible disabilities, and these changes were considered relevant clinical data for the purposes of the study. In parallel, experiments aimed at reproducing war wounds were carried out. For this purpose, injuries of different complexity were generated by irregular incisions, introduction of metallic objects, or fractures provoked with surgical instruments. The objective was to compare treatment methods, immediate closure, prolonged drainage, or application of experimental disinfectants. The surgeons recorded the progress of each modality, noting the time of healing, the appearance of complications, and the resulting functional state. The use of anesthetics also acquired a particular role in Ravensbrück. Evipan, a fast-acting barbiturate commonly used in surgery, was employed in controlled doses to induce general anesthesia. However, when a patient had undergone multiple procedures or was in a condition that doctors considered incompatible with further studies, high doses were administered, causing cardiac arrest. These deaths were documented as occurring during surgical interventions or due to post-operative complications, which allowed these executions to be integrated into the camp's medical record without causing administrative anomalies. The documentation generated in Ravensbrück was extensive. It included complete surgical histories, photographs of wounds at different stages, comparative tables of treatments, and detailed autopsies. Part of this information was presented at military medical meetings aimed at analyzing treatment methods applicable on the front, while other reports circulated in academic circles of the SS without public dissemination. By 1944, the complex had developed a stable structure for surgical experimentation, with trained personnel, specific instruments, and a continuous population of female prisoners destined for these studies. The continuity of these practices coincided with the emergence of another type of research within the camp system. In facilities located elsewhere, doctors began to focus on experiments that did not rely on incisions or transplants, but on procedures aimed at fertility control and direct intervention on reproductive capacity. These experiments required a different environment than that of Ravensbrück and were mainly developed in enclosed areas of other camps, where facilities were specially prepared for that purpose. In the administrative section of Auschwitz I, a brick building numbered as Block 10 was designated from 1943 for research focused on the permanent disruption of reproductive capacity. Its exterior appearance did not differ from other barracks, but the boarded-up windows and internal isolation indicated its specific function. The block operated as a closed laboratory, with rooms where gynecological procedures, controlled radiation exposure, and surgeries were carried out to evaluate sterilization methods that could be applied on a large scale. The goal was to find techniques capable of working with minimal infrastructure and reduce the time needed to reproductively incapacitate large groups of people. The regime had used conventional surgical methods since 1934 to sterilize individuals considered carriers of hereditary diseases, but the scale required during the war far exceeded the capacity of these procedures. The camp administration assigned Block 10 to 3 doctors with different lines of research. Each was seeking a method that could be quickly applied in facilities located in occupied territories, without relying on equipped operating rooms or highly specialized personnel. The first line of work was led by Horst Schumann, who had gained previous experience in the Reich's euthanasia programs. In Auschwitz, Schumann installed X-ray equipment configured to concentrate the radiation on the pelvic area. The procedure consisted of placing the prisoners in front of the machine and exposing them to high doses for several minutes. The intensity of radiation applied far exceeded the standards used in medical diagnosis and aimed to produce irreversible damage to the reproductive organs. Although no immediate effects were perceived during the exposure, Schumann recorded that in the following days, extensive skin lesions appeared, accompanied by other symptoms resulting from acute radiation exposure. To verify the result, patients were subsequently subjected to surgical interventions aimed at evaluating the state of the ovaries. The extracted tissues were preserved for histological analysis conducted outside the camp, and the reports indicated that the radiation destroyed the follicular function. However, the doses necessary to achieve permanent sterilization produced lesions in adjacent organs and raised the post-operative mortality, which made it difficult to implement the method on a large scale. Simultaneously, Karl Klauberg developed a non-radiation-based approach. Klauberg, a gynecologist with experience in infertility treatments before the war, sought a method that did not require surgery. His procedure consisted of introducing an irritating chemical through the cervix intended to cause intense inflammation of the fallopian tubes. The purpose was to generate a scarring process that would obstruct them permanently. Klauberg performed the applications in a room equipped with gynecological tables and recorded the volume of solution used, the time between injections, and the physiological reactions observed. In some cases, he used contrast X-rays to verify the obstruction of the tubes. He considered cases successful where the contrast medium did not manage to pass into the abdominal cavity. Patients with partial obstruction underwent new applications, and extended follow-up was conducted to confirm that the scarring did not reverse. The reports that Klauberg sent to superiors included calculations on the operational capacity of the method. He estimated the number of injections that a single doctor could administer in one day, the minimum necessary infrastructure, and the training required for the assistants. His documentation reflected an interest in developing a scalable procedure that could be applied in improvised medical stations. Although the records describe cases with effective obstruction, they also point out frequent complications such as severe pelvic infections, prolonged fever, and hemorrhagic disorders that limited its application without constant medical supervision. A third approach, overseen by Eduard Wirtz, involved resorting to direct surgical techniques. The operations included the removal of ovaries in women and of testicles in men considered suitable for brief procedures. These surgical acts were performed in rooms of Block 10 equipped with basic instruments. The method, although technically effective, required more time per patient and frequently generated complications due to the limited sterile conditions. Post-operative infections and hemorrhages were common, and the internal statistics showed significant mortality in the days following surgery. The results did not offer advantages in terms of scale compared to conventional surgical sterilization performed in civilian settings during the 1930s. In certain cases, the medical staff conducted additional studies to analyze reproductive physiology at different stages. These studies included the evaluation of ongoing pregnancies after ovarian removals, in order to record hormonal evolution and subsequent obstetric outcomes. These procedures expanded the accumulated documentation and provided information on the endocrine impact of the interventions, although they did not directly contribute to the development of mass sterilization methods. The records of Block 10 consisted of clinical sheets, operative descriptions, and subsequent tissue analyses. Part of this information was transmitted to research institutes associated with the regime. The data included rates of achieved obstruction, radiation exposure times, infectious complications, post-operative evolution, and anatomical observations obtained through verification surgeries. Each set of results was interpreted with the objective of determining which technique could be more widely replicated in territories under German control. By the end of 1944, Block 10 had generated a considerable amount of information on both non-surgical and surgical sterilization methods. Although none of the procedures fully met the expectations of speed and safety sought by the central administration, the research continued to provide data to the regime's medical system. The existence of these studies consolidated Block 10 as a space reserved exclusively for intervention on reproductive capacity, separate from other areas of the complex where research with different purposes was conducted. In those areas, located mainly in Birkenau, other doctors developed lines of work focused on specific hereditary characteristics and the systematic comparison of individuals with shared biological traits, using selection criteria different from those employed in Block 10. Josef Mengele was assigned to Auschwitz in May of 1943 as an SS doctor attached to Birkenau, with responsibilities both in the selection of new arrivals and in the health supervision of the sector. His training in medicine and anthropology, along with his previous collaboration with Ottmar von Verschuer in twin studies at the Kaiser Wilhelm Institute, facilitated his use of the camp environment to expand work on comparative anatomy and biological inheritance. The constant influx of transports and the administrative structure of Birkenau allowed the immediate identification and separation of individuals with characteristics of interest for his projects, in particular pairs of twins, people with congenital deformities or unusual body proportions. The procedures began directly on the ramp. During the selections, Mengele requested the identification of twins or siblings with a similar appearance. Once located, they were separated from the rest of the transport and directed to specific barracks in Birkenau. This immediate classification made it possible to have subjects in better physical condition than the average of the camp and to keep them in more stable conditions for prolonged observations. The goal was not to improve their welfare, but to ensure that the data obtained were not influenced by extreme deterioration or advanced diseases. The barracks intended for these groups had a different layout, with a lower density of occupation and access to slightly higher rations to maintain physiological parameters useful for repeated measurements. Mengele's work was structured in systematic stages. The first consisted of collecting anthropometric data. The twins were measured with calibrated instruments to record cranial proportions, bone lengths, body perimeters, and facial angles. The measurements were repeated at regular intervals to document growth variations and differentiate between genetic and environmental factors. These sessions included standardized photographs taken from various angles, as well as anatomical drawings made by prisoners specialized in scientific illustration. The dataset sought to establish structural comparisons between identical twins, fraternal twins, and individual subjects with unique morphological characteristics. The next stage consisted of obtaining biological samples. Blood extractions were performed in volumes greater than usual for serological studies. Part of the blood was sent to Berlin, where von Verschuer coordinated complementary analyses aimed at examining immunological markers and hematological characteristics in genetically identical pairs. In some cases, Mengele performed cross-transfusions between twins to observe physiological compatibility and detect differential reactions. Internal reports describe these interventions as evaluation procedures, aimed at determining the stability of immunological parameters among individuals with identical genetic composition. In addition to blood samples, injectable procedures were performed with substances of varied composition. The purpose of these applications was to observe comparative responses between two subjects who shared the same genetic basis. The results were recorded through daily controls of temperature, skin appearance, and basic organ function. The documentation generated contained charts of parallel evolution with special attention to the synchronicity or divergence in clinical progression. Another line of work focused on ophthalmological studies. For this, Mengele conducted systematic examinations of iris coloration and ocular structure, complemented by obtaining samples for later histological analyses. The ocular piece, once preserved, was sent to collaborating institutions for microscopic studies on pigmentation and variations in tissue development. Although chemical interventions were undertaken to modify the iris coloration, the available records show a lack of clinically relevant results and describe only structural alterations as a consequence of the procedure. The clinical sessions also included general medical examinations aimed at maintaining a continuous record of the physical condition of the subjects. These checks covered weight, heart rate, breathing, and other basic parameters in order to have consistent comparative data before carrying out major interventions. This accumulation of information allowed planning of internal anatomy studies whose results had to be analyzed with microscopic precision. Anatomical studies required complete dissections. To ensure these had comparative value, Mengele aimed to have both individuals in comparable physiological conditions. When he considered the phase of external observation and biological samples complete, he determined the moment when the parallel autopsies would be performed. The bodies were transported to the anatomical laboratory of the camp, where teams of specialized prisoners, working under supervision, carried out the thoracic and abdominal opening, the extraction of organs, and the processing of tissues for preservation. The brains were removed intact for further studies, as well as eyes, endocrine glands, and specific sections of muscle and bone. The dissections were carried out following established protocols with detailed lists of dimensions, weights, and macroscopic characteristics of each organ. The information was transcribed onto standardized forms that included side-by-side comparisons between both twins. The anatomical specimens that exhibited similarities or variations deemed relevant were placed in containers with fixing solutions and labeled with numerical codes. These materials were sent to Berlin under the category of priority scientific material for advanced histopathological analysis. Between 1943 and 1944, the set of works conducted by Mengele generated a large amount of data, written reports, and anatomical samples sent to various institutions. Although the resulting documentation was extensive, the methods lacked proper controls, and the conditions of the camp generated variables impossible to eliminate in a rigorous scientific study. Even so, the system continued to drive these practices with the purpose of obtaining usable information in broader biological and hereditary research programs. As the war progressed towards its final phase, the continuity of these works began to be affected by the lack of supplies, the saturation of the field, and the imminent presence of Soviet forces in the region. However, the lines of research were not immediately interrupted. The flow of samples, reports, and observations continued until the operational situation of the complex made it unsustainable. In parallel, other German fields were developing different studies, focused on infectious diseases, controlled poisonings, and tests with chemical agents, setting up a final stage of medical experimentation that would intensify in the last few months of the conflict. The transition from the experiments at Auschwitz to Buchenwald did not entail a reduction in brutality, but rather a shift in focus. In this camp, the experimental structure was concentrated in Block 46, a facility that functioned as an infectious diseases laboratory and operated with almost total autonomy within the complex. Its main purpose was to produce data applicable to the war, especially in relation to typhus, typhoid fever, and other pathogens that affected the German army on the Eastern Front. Unlike the camps intended for immediate extermination, Buchenwald worked with subjects who had to be kept alive long enough for the experiments to yield measurable results. The hospital-like appearance, with orderly beds and medical staff in constant activity, concealed a system designed to deliberately induce infections and record their progression with a precision that completely disregarded human suffering. The typhus program led by Erwin Ding-Schuler began in 1942 and grew in complexity as the German military situation deteriorated. Typhus, spread by lice and difficult to control in overcrowded conditions, posed a risk to both troops and prisoners. In Block 46, however, the disease was artificially introduced. Prisoners were divided into groups. Some received experimental vaccines, and others acted as controls without any immunological protection. The infection was induced through injections of contaminated blood or bacterial cultures, and in most cases, the disease developed with a devastating rapidity due to the general malnutrition in the camp. Ding-Schuler's records documented the progression of the fever, the appearance of rashes, respiratory deterioration, and cases of delirium. The mortality rate was high, and each death was followed by autopsies intended to correlate clinical findings with internal injuries. Experiments with typhoid fever, cholera, and diphtheria followed a similar pattern. Vaccines developed by German pharmaceutical companies were tested in consecutive series of prisoners. Each trial generated new mortality tables and evolution curves that were sent to military medical authorities. Block 46 functioned as a continuous human laboratory in which diseases were introduced, evaluated, and recycled with strictly operational criteria. In many cases, survivors of an infection were reinfected weeks later to test acquired resistance or to evaluate new variants of vaccines. Starting from 1943, the experiments in Buchenwald included the use of poisons and chemical substances. With the Allied advance on several fronts, the regime intensified its interest in toxic agents that could be used in special operations. Selected prisoners were exposed to alkaloids, irritant compounds, and neurotoxic substances. At times, the poisons were mixed with food, allowing the effects to be observed without the victim knowing. In other cases, they were administered through controlled injections. The progression of symptoms was recorded step by step: convulsions, paralysis, circulatory collapse. When death did not occur with the desired speed, the subjects were strangled or executed by similar methods to allow for immediate dissection and analysis of affected organs. The phosphorus burns trials represented another line of research. White phosphorus, used in incendiary weaponry, caused deep injuries that continued to burn upon contact with air. To evaluate potential treatments, doctors from Block 46 inflicted controlled burns on the arms, legs, or torsos of prisoners, testing experimental ointments and solutions. The resulting wounds were observed for days, recording the degree of infection and patterns of necrosis. The results rarely provided real improvements, but fueled reports that circulated among combat medical units. As the war moved towards its final phase, Buchenwald functioned as a living archive of medical data produced through forced experimentation. The records included lists of infected subjects, timelines of symptom onset, doses administered, and autopsy results. The structure of Block 46 allowed for a continuous flow of information that was seen as valuable by the authorities. However, the imminent German defeat led those responsible to destroy a significant part of the documentation. Crematoriums operated day and night, not only to dispose of bodies, but also to get rid of compromising files. When United States forces liberated Buchenwald in April of 1945, they found hundreds of prisoners in critical condition and direct evidence of medical experimentation. The laboratories kept labeled vials, bacterial cultures, statistical tables, and equipment used for inoculations. Allied doctors immediately began emergency care, but many of the survivors died days later due to irreversible damage caused by repeated infections, poisonings, and experimental procedures. The discovery in Buchenwald coincided with similar findings in other camps. In Dachau, pressure chambers, hypothermia tanks, and lethal experiment archives were found. In Auschwitz, the Soviets had recovered some of the documents from Block 10 and Josef Mengele's laboratory before the SS could destroy them. The scattered evidence confirmed that the camp system had operated as a coordinated network of human research, with each facility specializing in a particular set of experiments. After the war, the Allies faced the task of prosecuting those responsible. The doctors' trial, held in Nuremberg between December of 1946 and August of 1947, gathered documents, testimonies, and photographs into an extraordinarily detailed dossier. 23 doctors and administrators were accused of war crimes and crimes against humanity. The prosecutors demonstrated that the experiments were not only unethical, but also scientifically flawed. In many cases, there were no valid controls, the doses were inconsistent, and the procedures were modified without clear methodological justification. This revealed that the central aim was not to generate knowledge, but to apply violence under scientific cover. The sentences issued in August of 1947 included 7 death sentences and several prison terms. However, a significant number of doctors evaded justice. Some escaped abroad with the help of clandestine networks, others reintegrated into medical practice during the post-war period. The most notorious case was that of Josef Mengele, who fled to South America and was never captured. Others, like Horst Schumann, avoided significant sentences by claiming health issues or technical faults in the legal proceedings. The doctor's trial produced a momentous consequence. The Nuremberg Code, a set of ethical principles aimed at regulating medical research with human beings. Its fundamental premise established that voluntary consent was indispensable. It also required that experiments have a solid scientific basis, that unnecessary suffering be avoided, and that the risks be proportional to the expected benefit. Although subsequently other ethical documents expanded upon these principles, the Nuremberg Code became a central reference to prevent future abuses. After the liberation, the camps were dismantled and converted into sites of memory. However, the persistence of questions about how trained doctors with respected careers participated in these programs continues to be the subject of study. The combination of hierarchical obedience, racial ideology, and a total absence of ethical oversight allowed medicine to be transformed into an instrument of extreme coercion. The recovered documentation shows that many of those responsible acted with a mix of professional opportunism and uncritical acceptance of state policies. At the close of the war and the immediate post-war period, global medical research faced the challenge of deciding what to do with the data produced by the Nazi regime. Some scientists argued that, although obtained in unacceptable ways, the data could have operational value. However, later evaluations demonstrated that most of those results were methodologically invalid. The extreme conditions of the experimental context, the lack of adequate controls, and the variability in the procedures made the data lack precision. The ethical debate persisted, but the dominant conclusion was that such results could not be integrated into serious scientific practices. The history of Buchenwald, along with the experiments of the rest of the camp system, revealed the extreme to which a medical structure could go when subordinated to a totalitarian political project. The recovered files and the testimonies of survivors documented a network of practices that integrated medicine, administration, and coercion. And when the post-war period advanced towards European reconstruction, it became clear that the examination of these crimes did not end with the trials, but was part of a longer process to understand how science could be used as a tool of domination. In the following decades, historians, jurists, and bioethicists continued to examine these events to understand their origin and implications. This effort included the analysis of institutional structures, the review of contemporary medical practices, and the implementation of international standards aimed at ensuring that nothing similar could happen again. The memory of the victims was integrated into educational initiatives, museums, and research projects, creating a permanent framework of ethical vigilance that would continue to influence global medicine. These reminders continually underscore the importance of protecting world human dignity, always.